Good morning.
Oh.
Please, can you take your seats? We are ready to begin this session. Thank you very much. Yesterday, at the opening of the conference, we had the opportunity to listen to 3 outstanding keynotes. Joanne Wolf traveled us back to the roots of pediatric palliative care. Ana Lacerda illuminated some of the challenges and accomplishments that are present in pediatric palliative care. And Sophie, Victoria, and Elizabeth raised some key issues that we need to address as we shape the future of pediatric palliative care. And this morning, we gained some insights into artificial intelligence and the value that it may have for some of our children. The theme of this morning is pushing the boundaries. We push the boundaries when we have a vision. We push the boundaries, but we also venture into unknown trajectories. We take risks, but we also benefit of opportunities for growth. So pushing the boundaries is essential for the growth of pediatric palliative care. And we have 3 outstanding speakers today to share with us some of their knowledge and expertise in how they push the boundaries, but also raise some key questions of the process of pushing the boundaries.
Our first speaker this morning comes to us from Alberta, Canada. Professor Daniel Garros is a pediatric critical care specialist and will address this morning the topic of high tech. Is it an opportunity or a limit?
Okay. Thank you very much to the organizers to bring me here again. This is an incredible opportunity to be here with all of you. This poor intensivist here in the middle of this authorities and great people in the field of pediatric palliative care. So to me, it's a great opportunity. And now I know what Rome is having this 25-year jubilee celebration is because of the Maruzza Foundation, right? All the construction, all that, you're doing good. So thank you very much. No, I'm just joking, but it's a great honor to be here at the anniversary of the Maruzza Foundation. So thank you very much for this opportunity. So you guys gave me a very hard talk to do after the talk that you just heard. So initially I thought I was going to talk about artificial intelligence, but then I saw the topic, so I have to change my talk quickly. So we're going to talk about the issue of high tech. Is it an opportunity or a limit? So high tech is even in our homes right now, as you can see on this cartoon. So we are really living a different era, but probably my grandparents said the same thing when they were on their time. So we were going to talk about high tech is here. We're going to talk about from NG tubes to ventricular assistant devices. So we'll give you some examples and the benefits and risks. And can we actually do palliative care, pediatric palliative care there? And how do we react to all of this? So I came across this paper from my colleagues in Montreal, the Department of Pediatric Hematology Oncology. And this was a very interesting paper where they got an anthropologist to run rounds with the team for quite some time, more than a month. And the anthropologist, who had no clue about what he was doing, was totally shocked what he heard. And one of the expressions that came out of this study is one of the nurses said, is to determine when we stop, because we have no limits. We have no limit whatsoever to what we can do. So since we have no limits, well, I think that we are looking for some new ones in asking the parents what they think about it, in asking the child what he thinks about it, because we have everything. We have access to everything. So the title is The Death of Palliative Care. We'll come back to that. Just because we have it, should we use it? I always ask these questions, and we go into these topics with the parents many times in the ICU and in the hematology oncology. Just because we can do it, should we do it? We always have to remain the truth principle of veracity, telling the truth. But just because we can do ECMO on everybody almost, should we do it? And we go to the roots of the issue. This is two papers, one in 1993, and it says, what if hospice care becomes itself high technology, aggressive, costly healthcare, in order to remain true to his goal to maximizing quality of life? What are the implications for the goals and philosophical underpinnings of palliative care? And then 10 years later, 2013, another paper says PPC can decrease the use of aggressive interventions at the end of life, less use of mechanical ventilation or surgical procedures, fewer admissions to the ICU, and fewer deaths in the ICU. That would be ideal. So how can we make these two things 10 years apart, talk to each other, and be coherent at this point? So how much high-tech is really high-tech? That stretcher was really high-tech in the early days of the Hospital for Sick Children in Toronto. My ICU high-tech is what you see on the left. Can you actually, on your right, can you actually see the baby? Low-tech can be high-tech, depends where we live. So nasogastric tube feeding can be high-tech in North Sahara Africa for a baby that has chronic aspiration. Gastric tube feeding, tracheostomy, non-invasive or invasive mechanical ventilation, and so on and so forth. The feeding tube, people talk about Abraham Levin in 1921 creating the feeding tube, which makes very many kids happy, like you see in this little boy full of food in his belly. But it was an Italian, Girolamo Fabrici or whatever. I trained to say this, but when you're nervous, it's hard to say. D'Acquapente. He created in 1675 the tube to feed kids and adults, to bypass the nose, through the nose, back to the throat. And the interesting story, in 1870, Dr. Staton created the gastrostomy tube, and the first story is a boy who used to chew his own food, and then he'll spit it out, and he will put the food into his G-tube himself. So he had the comfort of feeling the food on his mouth, and he did that way. And starting and removing enteral feeding tubes is a problem, and you all remember the case in the US about removing. And this creates a lot of anxiety on the wards nowadays when we say no more feeding, no more hydration, let this child die alone without any support of any artificial thing. Well, NG tube was the last artificial high-tech thing. In the middle high-income world, high-tech is very different. So I'll tell you a few things. And I'm not going to go to AI, I promise. Video conferencing is one study in Australia showing that, pediatric study, that video conferencing with families, consultations in palliative care has shown that was cheaper and was very cost-effective and was very good, and the patients really like it. So actually, is the opposite what we think, that the patients will prefer all the time to have us present. This study showed that was actually very good. And the reason for Australia, like in Canada, these parents, when they have to move long distances, they have to bring all the ventilator, all the machines. It's a trip of a lifetime every time they come for a 15-minute visit to the hospital. So this was very good for them. So video conference was good. So in adults, they look at telehealth versus in-person early palliative care in this paper from JAMA and found that was as effective, equally effective, visiting a video or in-person there was no statistic differences in all the reports of the families and what the data that they look it up. So very good, very effective. Another field that is coming really strong is electronic patient self-reporting systems. So there's a lot of softwares there, and the patients are actually, children included, teenagers included, reporting their own systems back to the palliative care team, and controlling that is self-reporting protocols. So quality of life has been assessed, and communication was facilitated by this technology. So very good to look back and see what's going on. There is like the MyPal, is fostering palliative care of adults and children. It's an initiative that uses a game, a very serious game, Walker Scouts, and designed it to input patients, and that's a big grant from European Union to do that, and some of you may be part of this here. And the other one is this other one, MyQOL-T process, a research tool to help patients monitor their own systems and share them effectively with doctors. And that's the MyQuality chart on the bottom. The creator, this great physician, passed away in 2023. And the one that created the system, this is MyQuality, the one that created the systems in Europe, also Dr. Vasilius, passed away as well, both of them. So we honor them for these initiatives. So monitoring wearables. So every one of you probably has a wearable in your, now on your wrist, correct? In fact, there's a big fight about this, who created this. It actually was a medical industry that 35 technicians were stolen by Apple and went to create on the Apple Watch, and now there's a big lawsuit in the US about this. This study, pain monitoring, is actually showing that, as you can see on the graph, after 7 days, already a reduction on pain and suffering in certain indices in children wearing this machine and reporting back to the center, the palliative care center. And not only reporting back, but the kids were told after wearing this machine, strategies, how can then they decrease their pain. So there was a significant improvement. Other smart applications in smartphone, Pain Squad and the smartphone, adherence to pain reporting was 68%, and trends improvement in pain intensity, pain interference, and quality of life were significant. And in Denmark, there is a very good application as well, quality of life in adolescents and young adults, with already 81 kids study with very good results. So wearables are here, so the patient is wearing it, and a central station control and sees what's going on. This is from one of the companies that does this thing. It is actually all the vital signs are recorded, and we're going to try to do this in our center in Canada to avoid the patients to bring all their equipment and come back and not just give you real-time information, but reports back to the system what happens over the last 2 or 3 weeks. So it's really good tool. We'll see if we can play this video that talks about a patient.
I remember I was in a deep sleep, and I was like, why is this phone ringing? They said, Miss Lee, are you okay? I said, I'm fine, I'm sleeping. I was having a good dream. And they said, your sats are low, are you okay? And I was like, you know, I didn't know anything about what I was feeling when I was asleep. And the next morning they came and they swooped me in the ambulance and brought me to the hospital.
You know, when you get on the phone with them and they're very scared and they don't know what's going on, and we have to call an ambulance for them and they get readmitted, it really puts things into perspective, because they may not have thought that they were that ill, and then we're calling an ambulance for them and they're being readmitted. I've heard so many times how we've saved their life. Capacity.
So how we saved the lives. The guy didn't even know that he was sleeping and his sats are very low, so an ambulance knocked at his door in the morning to take him to the hospital. Virtual reality. So virtual reality can use in 2 ways, as a tool for PPC and a teaching tool also for us. So this, there are some studies showing that kids can be transported to an immersive environment outside their lives. They cannot do to the beach in Amalfi Coast or anything like that, like I did last week. Beautiful. And they can be there virtually. They can go to Machu Picchu to get to know virtually. So this is, and Maruzza Foundation brought 2 Japanese guys, remember that time? They came here and told us the potential that this could do for kids in palliative care. So an immersive experience can reduce stress, anxiety, enhance mood, and even have an analgesic effect. So buy one, try in your service, okay? The doll is dead. Who is the doll they're talking about? The old doll that we use for simulation. Now, virtual reality, they already have 16 students, 4 facilitators, and showed that was enjoyable, enabling and promoting peer discussion, high impact. This is training, decision-making, training people to learn palliative care with simulation, not using a doll, but using a virtual reality tool. And was a question about loss of sense of realism and authenticity, but a great advantage was no issues with any freedom of information or having to use patients for teaching. So the doll is dead. So we still use the dolls, though. So this is another video of another very high-tech thing that we are using in Edmonton.
The ability to be able to get him out and get him exercising, building muscle, becoming stronger, increases our chances for a quick recovery once we do get the gift.
So I'm really hoping that we can improve the quality of life within the hospital during that prolonged wait time.
And to see him becoming stronger and pushing him to his limit instead of to the limit of the machine is something that's really, really, really beneficial. To know that we're going to be able to get him as strong as we can before we take him home really gives him a lot more hope.
Did you see him pushing his heart and his heart hanging outside the body? That's exactly it. And what did the doctor said? Improving his quality of life while he's waiting for a transplant. So these are the Berlin heart now decreasing significant size. Let's stop here. I went from NG tubes to ventricular assistant device. What a contrast. What an incredible journey. But where do we draw the line? Where we're going with this? Is this an opportunity, I was asked, or a limit? Look at the left side. This is your right side. Left side. This is a kid with on an ECMO machine, and that black thing in the middle is a dog. So we do palliative care on a daily basis in our patients in the ICU. So this is bringing palliative care to the bedside, to the right side where you cannot even see the patient. So many machines. Is this an opportunity or a limit? So we're talking about palliative care in high tech. Sometimes it fails, and you can have a very quick, I'll tell you that, a very quick death. So what happens? High tech may distract us and push death aside. High tech, however, can give the gift of time. So it's very incredible, these two contrasts, that you can die suddenly if that pump fails, or you can have death pushed aside, but at the same time, the parents are telling us, you gave us the gift of time. So, should we consult palliative care in every case of ECMO? This is a study that showed that if you don't obligatory ask for a consult, they did a survey in Salt Lake City, and the staff said, but if you consult palliative care while you're doing ECMO, that is giving up on families. 42% said that. And there's poor acceptability of other team members to have palliative care there. 41% said that. So there's still a wrong vision, wrong view of palliative care being the end of life only. And then there's now a movement to actually bring palliative care palliative care as an obligatory consultation for all the kids that go on VAD or ECMO or lung transplant or bowel and intestine transplant or heart transplant. And that is increased involvement, greatest medical complexity, and higher prognostic uncertainty are the situation that we should get palliative care. So we may have to consult ourselves If they're not calling us, sneak your nose in the ICU and say, I think you guys need to call me here. This is a study, several studies here, VAD implementation, ventricular assist device. 4 out of 93 kids in this paper had palliative care consult, but 93% had palliative care consult at median of 36 days prior to death. That's great, but 62% of which were performing prior to device implantation only. So I wish we were like 100% prior to device implantation, right? In my center, we did a study and looked at 2 eras, and we had palliative care consult in the first era for ECMO, VAD, mechanical ventilation, and continuous renal replacement therapy in 15% of patients. In the last era, since 2019, we're now to 52% of patients. Still way to go, but we're doing better. And the Center for Advanced Palliative Care recommends an ECMO consult for every kid on ECMO. Palliative care consult for every kid on ECMO. And that is happening between 19 to 100% of centers with automatic consultation. So VAD can fail, and this is lots of studies on how the parents feel and how to do the VAD. And we wrote this paper about compassion ECMO discontinuation. And we describe 4 steps. So if you're interested in looking how to do it in your service, this is the paper we published in Journal of Pain and Symptom Management, and from family meeting, clinical aspect, practical aspects, and how to do and how to deal with the staff afterwards. So this is a time to stop. There always a time to continue, but there's a time to stop. And this is a family who stop ECMO, and they are there praying with their child before disconnecting the child from the ECMO machine. So technology dependence, as I said, we are more and more having it. This is our center. Look at all the kids dying in the ICU, in the cardiac. 93% are with mechanical ventilation, but 54% are on ECMO. And Dr. Wolf's group in Boston has done the same study, and they found almost the same thing. 46% kids that died in the cardiac ICU were on ECMO. A lot of them were on the ventilator. And look at that, 18% when parents never realized that the kid was dying. Parents really needed to get the view from palliative care much early on. And the same thing we're seeing. So what I want to finish is with this paper that I told you, that was the anthropologist and the group there in Paediatric. What did they say at the end of the paper? The team decided that no patient could be enrolled in a phase 1 clinical trial without previous encounter with the palliative care team. The unit's management is also committed to promoting a better knowledge of palliative care among families, particularly by introducing earlier in the care trajectories. So they need to look it up, they need to study, and they came to this conclusion. So it's a good end for something. Is this kid alive or dead? There's no heartbeat. There is the kid watching TV, watching a video. This is where we are. Technology does not define who you are. You are a patient. You are little Johnny. You are no heartbeat, but you are playing with your dad on the floor on ECMO. So Children's Palliative Care put focus on living. This is in our newspaper in Edmonton. So in conclusion, the same child that has the VAD needs that stroke in the head with the hand of the nurse, the physician, the palliative care team. So is there a purpose for what we do? High tech is to keep kids alive. Good quality of living, not quality of dying, is what we aim for. There is an incredible role for PCC in all of this, what we do. And how to achieve that is consult PCC earlier. We need to consult ourselves sometimes. Convince your colleagues just about the PCC role. And they run in parallel, not just at the end of life. Thank you very much.
We have time for 2 questions or comments from the audience.
That was a lovely presentation. Thank you. You've gone from 15% to 52%, and how do you increase that further?
So what was the second part?
How do you increase your percentage?
How do we do it?
Yeah.
Okay, good. So that's a very good question, Ross. How did we increase the percentage? Number one is the palliative care team snooping around the ICU more and more. Number two, having people within the ICU that has a special interest in palliative care, which is me. I'm here and learning with all of you. So being an integral team, part of the palliative care team. And I do a lot of things together with the palliative care team. So an influence from inside into the palliative care team really help. And the next thing is also calling the palliative care not palliative care. We call it assist team. And there's assist is an acronym for supporting families in difficult times. And so that increased our consultation rate by like 300%. So we changed the name. People don't have that connotation that is end of life. Unfortunately, people that are not like you, they know this is not end of life. They still have that thing in their mind that end of life care is palliative care. And so when they changed the name of the team to assist, now even my colleagues who are very resistant to call palliative care before, they introduced the team like this. I'm going to call a wonderful group of people with a psychologist, social worker, good doctors that will do continuation of care, even outside the ICU, and they even go and help you at home. But they are a supportive service. And boom, everybody's now calling them. So I think those three things. And actually being demonstrated in the literature already. There's a paper from Toronto, there's a paper from Texas showing that change in the name increased dramatically. It's controversial, but increased dramatically the consultation rate.
Thank you very much, Doctor. Actually, I was fortunate to spend 6 months in Alberta with the ASSIST team. So that's nice to see you again. And one thing actually we could say, if I could add to the points you just said, is actually having champions within the ward. So in the cardiac ICU, if I remember, our biggest champions were the nurses there.
That's correct.
Because they have actually connected, and they're the ones who actually would connect back to us and tell us, oh, we have this patient, would you like to come and talk to the team for us? And this is how we would actually go into the ward and say, hi, we heard about this patient, we could do this and that to that. So and it's just keeping on knocking on the doors. This is what I was saying. And just being connecting with your champions and creating more champions in other wards. Thank you very much again.
Thank you, thank you. Nice to see you here.
Daniel, I have one observation. The title of papers and a lot of the themes that you addressed were truly ethical themes. We have the technology. Should we use it? Do we have to use it? Technology is amoral. There's no moral value to technology. The moral attributes rest with the user. Are we going to use this technology on this patient and expect these outcomes? Do you engage, or in Alberta, is there an ethics team that's utilized perhaps in conjunction with palliative care?
Yeah, very, very good question. We do have the ethics, the bioethics, which I belong to, the bioethics committee as well. So it is very important that technology on itself is inert, right? So as you said, so how do we deal with this thing? So when there are controversies, for sure, we call the ethics committee, and the ethicist will come and do the consult and help. And we have a team of people that for hard decision-making processes, so it's a stepwise approach. So then when there is some controversy, even about a tracheostomy, which is very common in pediatrics, should we tracheostomize or not, then we call the ethics and we study the case. And if the parents say, yes, for sure, I want everything done, and the team says, no way, Jose, you're not going to get a tracheostomy. This is crazy. So then we have a conflict. Then we have a conflict resolution process. Yes.
So, Elvira, our next presenter is a I can call a personal friend and professional colleague who I've had the opportunity to partner with over the last number of years. Dr. Elvira Parravicini comes to us from Columbia University in New York City and is a native Italian. I think she'll be presenting in English. Elvira, please help us understand the extreme preterm newborn and where perinatal palliative care meets technology.
Thank you for inviting me. Thank you, Franca, for this invitation, and thank you to the Maruzza Foundation. This is a wonderful, wonderful network of people working for a right cause. And so I'm humbly a small neonatologist, and I'm glad to join you in this effort, helping babies and children have a good life. Maybe not too long, but good life. How do we advance the slides? This big one. Okay. Okay, so today I want to walk with you through a couple of definitions, the definition of perinatal palliative care, the definition of periviability, and the components of perinatal palliative care in the settings of periviability. And I will share a couple of experiences from my job. So what is perinatal palliative care? It's a plan of care for women who elect to continue the pregnancy with a fetal diagnosis of life-limiting condition, and of course the care for their babies. The babies are the object of that palliative care, obviously. This definition has been also supported by the main, let's say, American perinatal associations, such as the ACOG, the American College of Obstetrics and Gynecology. They published in 2019 a document which has been supported, endorsed also by the American Academy of Pediatrics. And this document clearly underlines the fact that perinatal palliative care is focused on maximizing the quality of life for the baby and, yes, and the comfort, basically, the big achievement. And this option is one of the several options that can give to women expecting with a diagnosis of life-limiting condition, so much so they can make a proper choice according to their principles, their values. Okay, so periviability has been defined by the American Academy of Pediatrics as a gestational age between 22 and 0 and 24 and 6. And is a stage where the fetal maturity gives to the baby a chance of survival, but the likelihood is not that high. So now we want to understand the component of the perinatal journey in the settings of this very low gestational ages, periviability. So we offer, we need to offer to a woman coming with impending delivery at such an early gestational age, counseling. And it's very important to be honest in the range of possible prognosis. We also need to give option for postnatal care, what we can do with this baby once it's born. And then there is the whole discussion about the postnatal care, which includes the possibility of resuscitation, admission to the NICU, possible redirection, because the conversation should continue in the NICU, and also the option of comfort care, which is the, let's say, the topic, the focus of perinatal palliative care. Okay, so the perinatal consult is like any other consult for any other life-limiting condition. We need to express and share with the family the diagnostic and prognostic status for that specific pregnancy and baby. For example, is the baby small for gestational age? Is the baby has been a pregnancy complicated by PPROM? There are associated anomalies. We need to discuss with our colleagues. There are pathologists with mom. And again, we need to provide data of survival in general, but also in our own hospitals. Now, another thing is the prognostic meaning to the family, no? Because parents have a very different view on prognosis than we do as doctors and nurses. We need to probe what is important to them. What is quality of life is one of the most generic thing that we can consider, and you know more than me. For a family, quality of life is good if the baby remains a baby throughout their life. For another family, quality of life means the child needs to be running and play basketball. And so we really to probe what they mean when they say we want a good quality of life for our baby. We need to respect the choice. Doctor, give him a chance. So maybe attempt a resuscitation, maybe limited. And obviously there are cultural and spiritual differences, which, you know, they are immense. So I'm not gonna talk about that right now. Now, what is the range of survival for babies born at 22 to 23 weeks gestational age? This is a review published by Japanese. They had the best survival in terms of numbers. As you can see here, at 22 weeks, they are in the 60s, basically the survival. However, in the rest of the world, it seems not to be the same. Here you have the neonatal network, the data from the United States, from the neonatal network, and from the Vermont Oxford as well. And you see that the numbers of survival at 22 weeks are around 30%. Now, lower number are than in England, 18%. In Australia, although the numbers are very slow, is basically no survival. And there is a big bias, obviously, behind those numbers. That comes from the fact that how many babies do you resuscitate at 22 weeks? So that's a big question mark. More specific numbers. This is a study from Spain where those data comes from a population over 15 years. Okay, so it's about 8,000 babies. And you can see that the approach in resuscitation really did not change over time. However, in all gestational age, aside 22 weeks, over time, there was a significant increase on survival. Here is the survival of babies with 22 weeks remain the same over time. Moreover, they calculate the survival of babies born at 22 weeks who receive resuscitation, and over those 15 years was only 8.7%. This is another interesting study, comes from a consortium in California. They have data about 9,000 babies. They collected over 122 hospitals. And because the question is, okay, survival, but what about morbidities? And on the left, you see that, and by the way, the red dots are babies born at 22 weeks, 22 to 23 weeks. On the left side, you see that those red dots increase. I put an arrow, overlap an arrow there to show you. So the more resuscitation was given, the highest was the survival. However, on the right, despite the increase in resuscitation, the survival without morbidities remain very low and the same over time. Therefore, the big question is, should we offer resuscitation and then go to the comfort care? And you know, the data they tell you, there is much more there. I just want to give you a background idea. And there is this interesting article authored by big names in neonatologists. And the title, you see, Community Consideration for Aggressive Intensive Care Therapy for Infants Less than 24 weeks. And one of the conclusion that I copy-paste for you below says the routine resuscitation at this low gestational age is not in the best interest of all infants and families, and so such decisions are better if individualized. So a lot of conversation with the family before starting and offering to everybody. Which leads to me to what do we do then in our conversation with the family. I mentioned a little bit before how honest we need to be with the, you know, the prognosis of these babies. Also, being those babies affected with a life-limiting condition, we need also to be very careful the way we talk with the families, because using expressions such as lethal or incompatible with life to try to maybe convince them one way or another one can be perceived by the parents as not respectful and create some distrust. And sometimes parents react in front of the negativity, let's say, of the doctor, trying to ask, we want everything to be done, no? We need to create an alliance with the families and get really their trust. And occasionally, infants can have a better prognosis than we expected. You never know. One thing that I always tell the parents, I follow your baby. Let's take the lead of your baby. This is a little vignette that collage that I prepare about parents' view on diagnosis and prognosis. Now, spina bifida is not life-limiting condition. There's nothing to do with low gestational age, but is a very common condition. And so on the left, you see medical pictures. They're pretty much horrible, although you know they show how the baby with spina bifida is. On the right are, I Google it, pictures from families, and they are smiling baby, growing baby, together with the family. And so we really need to probe that view that parents have. Regarding the postnatal care, as I mentioned before, we can offer a full resuscitation and admission to the NICU if the baby respond to the resuscitation. Or one option that I offer very, very often is the attempted resuscitation. I say, I offer you a routine resuscitation, which is endotracheal tube, surfactant, and see what happened, no? And if the baby doesn't respond, if we have to go to epidrip or cardiac massage or things like this, we can maybe back up because the baby is not responding, or comfort care. I also, in my conversation, always say, well, the baby can come to the NICU, but we'll stay in contact. We'll talk about, again, we make steps with the family along the course because the condition of the baby can worsen. And I want to let them to understand that we will not abandon the baby and the family, whatever is happening, in the good and the bad. And so I try to establish an alliance right there for the future. Now I want to give you a couple of examples, starting from the work of my program, which I created 16 years ago, Neonatal Comfort Care Program. And here are my team. So is me. I have an assistant medical director, which is a young neonatologist. I have a nurse midwife, a coordinator, a nurse educator, and we have a bunch of social workers. We have a psychologist working with us, chaplain, and then we have all the NICU staff and labor and delivery staff. They work with us as well. What is the role of the perinatal palliative team? I have a double hat, meaning when I meet the family, I always say I'm an intensivist. I like to save baby's life, but I also will not abandon you. And so I'm able to carry you and your baby, even if we need to go to comfort care, palliative care. But basically, in an institution where there is a neonatologist, as many of you maybe do, and then there is a palliative care doctor collaborating, the role of the perinatal palliative care team is to participate or lead those consults. Now, when the baby is born in my institution, I take care directly of those babies, and is basically end of life in this case, because these babies, if you offer comfort care, they live very short life. But then I continue the conversation once they are in the NICU, and again, this can be the role of a pediatric palliative care team. Our team also offers short and long-term bereavement to the family after the baby passes. Again, which are the goal of perinatal palliative care when we do offer comfort care to babies at this low gestational age, or when we do the redirection of care in the NICU? They are the same that we do with any other baby with a life-limiting condition. Bonding, maintenance of body temperature, colostrum care. We don't talk about nutrition, of course, because life is so short, and alleviation of pain and distress. And again, bonding, skin to skin is the #1 tool, which is good for bonding, which is good for maintenance of body temperature. Mom, dad, anybody can do skin to skin for those minutes of hours of survival. Again, we don't talk about nutrition, but we can do colostrum care. For family, for mom, is so important doing something for their baby. And so we can collect colostrum on 1 cc syringe, we can do oral swabs and take pictures, and that will be a beautiful memory for the family. Alleviation of discomfort and pain. But these babies, they have such a short life, and sometimes there is only heart rate, not even gasping, but we have, in case, aside non-pharmacological strategies, which are the tools that I mentioned with you before, we have plenty of medication. No baby will suffer ever. We have morphine PO, fentanyl intranasal, and again, the life will be so short that rarely I found myself in the situation to administer even pain medication. I want to spend a word about pre-viable babies. Sometimes, you know, a woman comes to the hospital, there is a impending delivery at 20 weeks, 21 weeks. Some of these babies are born alive, and I think it's very, very, very important for the family, for the grieving process, that we acknowledge that the baby was alive. And so in our institution, we have these guidelines, which I share with you. When such a situation happens in the delivery room, the neonatologists are not called, because it will give like a false hope to the family. Doctor, save my baby. No. But the midwife or the nurses, or wherever it's in the delivery room, will help mom doing skin to skin. And when the baby passes, they will call us, so then we can write a death certificate. And I think, you know, sometimes it's just one beat of the heart, but it's so important. It's like the society acknowledging that the baby was alive. Okay, and now I have very simply 2 clinical cases to share with you. So this case is title is Anticipatory Plan of Care, What If? As I mentioned before, I always tell the parents, you know, I'm with you, I like to save babies, but if things are not getting better, I'll be with you and we walk together. And I always say there may be a moment where you tell me, my baby's suffering too much, I want to stop, or I tell you, me and my colleagues are thinking that this baby can't survive in that situation. And so this is a family who came to us with twins. One of the 2, the little boy, had severe fetal growth restriction, and the family desired full resuscitation, but they are very concerned about quality of life. And when we talk about specifically what quality of life was for them, they really desire a child who can go to school, a child who can run, a child who can, you know, play with his friends, etc., etc. And so we talk about plan A, plan B, the future, possible redirection, etc. The babies were delivered by C-section at 27 weeks, and 27 weeks is higher gestational age. Obviously, it's not peri-viability, but the weight of the baby was so low, and the size and the fragility of this baby was so important that I share as a case. So the APGAR was 1, 1, and 7. The birth weight was 410 grams. It was intubated on mechanical ventilation, which is a very unusual situation for us at Columbia. We don't intubate anybody unless the baby is really, really sick. So definitely the baby declared itself right away. He had severe respiratory distress syndrome, was complicated later on with BPD, pulmonary hypertension, was mechanical ventilation, had episode of sepsis. At a certain point, developed liver and renal failure. And I remember the day when I was the neonatology on service at that time. I walked to the baby crib, and the father looked at me and he says, "The day came, right? That's the day." And I said, "Well, I was going to talk with you about that. You remember our conversation early on?" And so then we sit down with the mom, you know, we spend some times together, and we decide to redirect care. And so we prepare, in our unit, we have a room which offers to parents the night before going home with their baby to sleep there with the baby, to just feel how is then when you go home alone with your baby. And so we use that big bed in that bedroom. And so we had mom and dad. They were holding also the healthy girl. At this point, she was a feeder and grower, the big twin. And they held also the little boy in the beginning with nasocannula with oxygen, and then we took it off. And those are the little memory cast about with the feet of the twins. And the baby really did peacefully in his mom's arms with a couple of drops of oral morphine, but really, really comfortable after the compassionate extubation. And I think that was a very good case, because I think that if I didn't mention anything in the very beginning during pregnancy, would have been much harder than start a difficult conversation. And the other thing is, I'm fortunate because being a neonatologist, I had the lecture to offer continuity of care. And so I was there prenatally, I was there when the baby is born, and I'm there when we have this difficult conversation. And the other case, this is my last case, is early PPROM is not always a death sentence. So I want to finish with a positive case. This was a mom with a PPROM at 16 weeks. She developed oligo and then anhydramnios. She was admitted for risk of preterm delivery. At 23 weeks, she received betamethasone, and this family wanted full intervention. For them, quality of life was anything like survival, the heart beeping, that's it. So, you know, I share always plan A and plan B, but I knew what that woman wanted for a boy. So in the middle of the night, I was on call. This baby was delivered in bed and was a boy, was breech. It was 24 weeks. The weight was not super small, 580 grams. They call us, we put the baby on bubble CPAP. This baby was never intubated, never received surfactant. Was on CPAP for 2 months, at about 34 weeks gestational age, was weaned to room air. He had no IVH, no PVL, no ROP, and went home at 3 months of life. And this is him with mommy. I have permission to show pictures. Actually, mom was very proud. Doing skin to skin on CPAP with mom. And then when he went home with a sister, 3 months, and then 1 year, and then 4 years of age, and now he's 8. And he's like fine, neurologically speaking. So this was an exceptional case, okay? Not all the babies born in our hospital at 24 weeks have this outcome, but just to say that I really I follow your baby, let's see what he does, and he really did so well. The last one, though, is comfort care option. This was a case of a PPROM very early at 22+4. Mom presented with contraction, with chorioamnionitis. There was no time for steroids, but definitely the conversation was, let's offer a short but beautiful life to this little boy. She delivered basically shortly after she came. The upper was 2 and 1. This baby, we never saw a gasp or a breathing or anything, but the heart rate was there. His weight was 485 grams and stays with the mom, skin to skin, and he died about 1 hour of life and was very, very peaceful. And with that, I thank you.
Again, we'll take time for 2 questions or comments.
Hi, good morning. I'm Silvia Alegría from Lima, Peru, and I understand that viability in maybe Colombia, New York, but in other parts of US, you don't have the same access to these good outcomes, as well as my country and other places. So you think we should do it like in weeks or on our own viability records? And how much should we say it's good, like survival, 30%? 20%?
So I show, in the very beginning, I show like a review with numbers of other different places. And again, you have to deal with the situation where you are. We had babies born at 24 weeks who die, or they go for comfort care. I mean, that was a very good case, and I like to share. But again, the situation, you know, medicine is a very dramatic place to be. There are no rules, basically. I mean, few rules. And so follow the parents and follow the patient is the best rule, because I am in medicine for many, many years at this point in my life, and I saw things that very unexpected, in good and bad. And so you have to take account of your institution, situation, country where you live, but also the single patient. Look at the patient and you'll know which way to go.
Hello, thank you for the wonderful lecture. I'm Susanna, I'm from Prague, I'm from NICU. My question is, we know that positive framing of the neurodevelopmental outcomes of the tiny babies or the babies who've got this premature rupture of membranes and so on, that the positive framing has a major impact on, how the parents actually decide to, which possibility they decide to pursue. So my question is, do you have some kind of a standard or some kind of report with the gynecologist, like how early do they call you to do the consult? Because we sometimes know that the neonatologists, they actually, frame it in a little different way. As you said, it's not always a death sentence. Thank you.
Yes. So up to a few years ago, we offer resuscitation to families when the baby is born at 23 weeks and higher. I believe 1 year and a half ago, we started attempting resuscitation at 22 weeks if the family asks for that. But starting at 25 weeks, we do offer resuscitation as the only choice because our survival is close to 90%. And also the morbidities are very low. And so at 25 weeks, there is no discussion. Below 22 weeks, there is no discussion. And 22, 23, 24, we tell them about our numbers, general numbers. We try to honestly present what will be the life of that baby, and we decide with the parents, basically, yeah.
Well, thank you very, very much. I have
Just to add that some of our staff members in Greece at the Pediatric Palliative Home Care Service attended your training programs online. They are outstanding, for those who are interested. Now, our next speaker is Ricardo Martino Alba. He's the head of Pediatric Comprehensive Palliative Care Unit at the Niño Jesus University in Madrid, Spain. He has designed the first pediatric palliative care system in Spain and has worked strategically on 2 levels. And I'm saying that because his work has been within the healthcare system of hospitals. First, by providing training to physicians, psychologists, social workers, and nurses. And second, by influencing the healthcare structures so as to provide humane palliative care to children by focusing on the child as a living human being and promoting home care instead of hospital care. Thank you.
I'm glad to be here 12 years later, and it's an honor for me that the organization has thought of me to replace Julie Howard. But obviously, I'm not Julie Howard. Don't set your expectations too high. The topic we are going to speak about this moment is transitional care for young adults, for everyone. Transition is a word with different meanings. I have chosen one of them to explain. To change or make someone or something change from one form or situation to another. Some individuals are required to change their healthcare providers due to age. The goal of planned transition is to optimize care for sick young persons throughout their lives, especially those with special needs. In pediatrics, transitions are common. There are transitions, neonates, infant, children, young adolescents. It's not a strange thing for us to make a transition. When we speak about pediatric to adult transitions, when a patient approaches the age for adult care, a transition is considered. But the first question is, what is adult care? There are many adult care ages because of the different health systems, different culture, and different organizations. Therefore, not all transitions are made at the same age. Can there be a transition in pediatric palliative care? Years ago, no one proposed a transition because of children died in a short period of time. Now, in pediatric palliative care, transitions are considered because there are patients with long-term conditions, children with chronic conditions with high complexity. If the patient has an incurable disease and in an irreversible phase with a life expectancy of years, a transition may be considered in pediatric palliative care. And this situation, this transition, has benefits for the patient because of an pediatric environment possible. We can't address so good some needs of the patients, medical needs or social, spiritual needs or family needs when the patient are married or lived in couple. more and more we care children with chronic conditions with high complexity. And to care for highly complex patients, certain criteria must be taken in account. Person-centered care, needs-based care, comprehensive care, interdisciplinary collaboration, the value of symptomatic treatment, the prioritization of care, and support for the child and their family. To initiate a transition, these criteria should be guaranteed by the receiving teams. If the best interest of the patient guides our decision-making in pediatric palliative care, is it really in the patient's best interest to change the responsible teams? There are many factors which can condition this transition process. We have named these complexity factors. Severe disability, severe cerebral palsy, dependence on all basic activities, pediatric body size and weight, in metabolic or mitochondrial diseases, difficult to control neurological problems such as dystonia or refractory epilepsy, severe intellectual disability, or the presence of different devices common in the care of this type of patients. We can take care of the patients in pediatrics, but these situations can make that more or less 20% of the patients, of the adult patients, are cared by pediatric teams. Other conditioning factors for a transition could be exclusion criteria. When the death of the patient is expected within less than a year, should be made a transition with this patient, or the lack of adequate resource, an non-existing resource, or an resource who does not match pediatric associated complexity. So that before to initiate a transition process, it's essential to consider some things. Who is the patient and what does she need? Is there a transition program developed for this type of patient? Is there a receiving team? Is the receiving team competent to provide the care the patient requires? And the last question is, can a transition be carried out for this patient? To do or not to do? That's the question. Which children should transition to adult care? To which professionals? Between specialties or from pediatric palliative care teams to adult palliative care teams? And which children should not be transferred to adult care? The transition is a process and is also a period in which both teams work together. And the transition must be planned, must to be informed. We have to consider other options if the transition is not possible, and it can be or not successful. And this is a new concept, the reverse transition. Sometimes adult teams receive patients with conditions acquired during childhood with complexity factors that make them unsuitable for adult care networks. When this occurs, a reverse transition process can be initiated by the adult team. In our team, in our system, we have developed two protocols, one for normal transition and other one for the reverse transition. When we take care of patients older than 18 and the exclusion criteria are not present, we can contact with the adult team, and if the adult team feels themselves competent, we can make the transition. Sometimes the adult team takes care of patients with these high complexity factors. They can contact us. We can work together to help them to control such type of symptoms of difficult control. And if it's possible, we can make the transition. And if it's not possible, the reverse transition can be made and the patient come to us. In some countries, there are successful experiences where specific teams and units are created to care for these highly complex patients. Ideally, these units for chronic complex conditions acquired in childhood should be located in a general hospital, not in an only pediatric hospital, be multidisciplinary, including gynecologists, neurologists, include surgical procedures, provide home care, and respond comprehensively to the patient's needs. Oh, sorry. I recommend you this recent review made by Franca Benini and collaborators about this topic. They conclude that the transition process is not limited to a change from pediatric to adult services. Rather, it includes the entire process of the development of the child and requires interdisciplinary management with proper planning and collaboration among professionals of pediatric and adult teams. So, caring for adults suffering complex chronic conditions since childhood is not an impossible mission, but nowadays, word is not enough. And many healthcare systems are not prepared to offer safe transitions for everyone. Thanks.
We have some time for a couple of questions. Or comments, or challenges. Okay, there is one back there. Wait.
Thank you very much. I'm a paediatrician, so a disability doctor from Australia, and I work in a similar space, but I'm not a palliative care physician. You must work in a much more compassionate healthcare system because we have enormous pressures to transition our patients with the list of complexity you described to adult care. And I suppose there's a recognition that these childhood disabilities are now becoming conditions of the lifespan. And in fact, the European Academy of Childhood Disability have changed its name to European Academy of Childhood Onset Disability. I suppose I'm making some comments about how we have battled that interface. One particularly difficult point is that adult medicine in Australia is very much focused on everybody having an advanced care plan, which sometimes equals a not-for-resuscitation plan, and that's very contrary to what we experience in paediatric care. Have you had those similar barriers? Is that one of the things that has limited the successive transition and caused reverse transition in your hospital system?
In Spain there are different experiences. In some places there are successful experiences, but in other places there are no possibility of a good transition. Transitions be made, but parents knock off the door of the pediatric team and
Yes.
requires, please, we want to come back to you. But there are many good experiences, and I am in agree that to make a good advanced plant care, that is helpful also for the transition. Thanks for your comment.
Thank you.
I think this is a very good point, because sometimes even the adult physicians and teams come to the pediatrician to ask for consultation when they take up an adult child that we've cared for many years.
Yeah, we had an experience like that. The adult pulmonologist saying to us peds over the coffee break downstairs in the cafeteria, what are you guys doing with these children that you're sending to us now? We would have stopped treatment 10 years ago, 8 years ago, 5 years ago. Now you're leaving us with all these problems. What are you guys doing? So we invited the respirologist adult to spend a month with us in the ICU, and also in the wards, on the oncology department, on the metabolic disorder department, and they changed their minds. So they actually now have a transition team, and they are doing much better before. But we were receiving those requests before from the parents. Can we go back to peds?
Yes. We have experiences with surgical procedures, simple for us surgical procedures like gastrostomy to live better. And in adult teams, it's not so common. And so bioethical resonance come that there has no sin.
I think it's important to acknowledge the fact that family-centered care, patient and family-centered care, started in pediatrics. And the adults come to it lately. So it's a good ground to understand the nexus of decision-making in the pediatric world is so different than in the adult world. I really appreciate Daniel's model of inviting the adults into the pediatric ICU.
That is happening also in the cardiology world, because now the complex cardiac conditions, right? They are becoming adults, and they had no clue what is this, a Fontaine, what is that? So now we have special teams that do the transition from cardiac peds to cardiac, and they participate in the peds rounds, and in the evening they do, in the afternoons when we do the surgical decision on the older kids, they come.
For cardiological surgical procedures, we have also such teams in Spain, and this is a good work together. And the adult cardiologists are expertise in congenital cardiopathies.
We would like to thank you very much for your contribution. And thank all the speakers for the excellent presentations of this roundtable.